Hello everyone. So if a patient, a pregnant lady, she comes to a clinic and she is more than 20 weeks pregnant. So she's pregnant and she was normotensive before that. So previously normotensive, now she's 20 weeks pregnant and her blood pressure is more than 140 by 90. Then we have to confirm that blood pressure. So we take another measurements that should be at least 4 hours after the first measurement. So we take two measurements and they have to be at least 4 hours apart, and the diastolic pressure should be more than 140 and systolic more than 90. Then we label it as pregnancy induced hypertension. So there needs to be certain criteria that need to be filled. So firstly, over 20 weeks, previously normotensive, and 140 by 90 and 4 hours apart. So that's pregnancy induced hypertension. And on top of that pregnancy induced hypertension, if the patient is also having a protein urea of 300 mg in 24 hours or more than that, or so either this or end organ dysfunction, and we will learn about different symptoms of end organ dysfunction later. So now if she has pregnancy induced hypertension plus protein urea, then that is preeclampsia. Okay, so preeclampsia is when there is pregnancy induced hypertension plus protein urea or organ dysfunction. Okay, so that's preeclampsia, and it usually resolves after 6 week postpartum, but it's not like we wait till 6 week postpartum to diagnose preeclampsia. Okay, so we diagnose it with these criteria. Okay, so there are certain risk factors that are associated with development of preeclampsia. And why do we need to know these risk factors? Because if a person has one or more high risk factors or two or more moderate risk factors for preeclampsia, then we have to give her low dose aspirin, and that reduces her chances of developing preeclampsia. Okay, so we start the low dose aspirin at optimally at 16 weeks, but we can start it between 12 to 20 weeks. Okay, so we start here and we move till term. Okay, so we keep giving her low dose aspirin till term when she delivers the baby, and after that of course we stop. So that's the importance of knowing these risk factors. So what are these risk factors? So high risk factors are if she previously developed preeclampsia or eclampsia. Again, and in obs and gynae, these are usually the most important risk factors that a person previously had that disorder, or the patient has chronic hypertension. So if she already has chronic hypertension, then she has a higher chance of developing preeclampsia or eclampsia. Or if she is diabetic, or she has any autoimmune disorder like antiphospholipid or SLE, or she has CKD. Of course, CKD leads to increased blood pressure, or she has multiple gestations. So twin pregnancy or molar pregnancy, they are also high risk factors for preeclampsia. And the moderate risk factors are if the patient is nulliparous. So if it's her first pregnancy, or she has family history of preeclampsia. So if she has previous history, like the patient herself had preeclampsia in her previous pregnancy, then that's high risk factor. If another member in family had preeclampsia, then that's moderate risk factor. Or her age is more than 35, or she is overweight, or she had gestational diabetes. So gestational diabetes is moderate risk, and type 1 or type 2 diabetes is high risk. And if she has other factors like small for gestational age baby, or poor history of pregnancy outcome, or IVF, or interval is more than 10 years, that's a moderate risk factor. Or she is poor socioeconomical background she has, or she is non-Hispanic black patient. Okay, so these are moderate risk factors, and if there are more than two of these, or one or more than one of these, we have to give her aspirin, low dose aspirin. Okay, so what's the pathophysiology? Why does this disease occur? So normally what happens is that we know that this is placenta and this is normal uterus. Okay, so what happens is that the placenta, it invades the uterus. We all know that. Okay, so the placenta, it has two layers. We know that there is cytotrophoblast and syncytial trophoblast. And normally what happens is that the cytotrophoblast, it invades the blood vessels. Okay, so it's invading the blood vessels, and what does that do to the blood vessel? The blood vessels lose their muscle. So we know that arteries have smooth muscles in their in their walls, and when that smooth muscle wall that get replaced by cytotropoblastic invasion, that kind of make the blood vessels looser, so they dilate. So these blood vessels are dilating due to this invasion of cytotrophoblast, and this leads to increased blood flow. But in preeclampsia, what happens is that the invasion is incomplete, it's patchy. Okay, so we see that there is invasion, then there is normal muscular layer, then there is invasion. Okay, so what does that do? That decreases the expansion. So that decreases the compliance of these blood vessels. They stay small, their lumens stay narrow, and that leads to hypoperfusion. This placental hypoperfusion then leads to a vasoactive substance release. That's normally every tissue in the body does that. When it's hypoperfused, it leads to release of vasoactive substances that increase the flow. But what do these vasoactive substances do? They cause platelet dysfunction and vasoconstriction. So we need to remember that it causes two things: platelet dysfunction and vasoconstriction, and these are the two factors that lead to the systemic effects of preeclampsia. Okay, so this leads to maternal hypertension, and the platelet dysfunction, it also leads to certain other effects on different organ system. That is termed as organ dysfunction. Okay, so okay, this is, I think, pretty easy to understand. There is patchy infiltration, and because of that patchy infiltration, there is decreased blood flow to the placenta, and that leads to release of vasoactive substances, and that leads to endothelial damage and vasoconstriction. That vasoconstriction leads to maternal hypertension and endothelial dysfunction that leads to end organ dysfunction. Okay, so this is a table showing different mechanisms of dysfunction of various organs. So in kidney there is glomerular endothelial dysfunction. So endothelial dysfunction happens, and this happens to the glomeruli. So glomeruli, we know they are the capillary, a bunch of capillaries that is present in Bowman's capsule, and from there the filtration happens into collecting in the tubular system. Okay, so if this is dysfunctional, that leads to proteinuria, because the capillaries, the glomerulus, it keeps the protein from entering the urine. So if these glomerular capillaries are dysfunctional, that would lead to leakage of the protein. So proteinuria in itself is also a manifestation of organ dysfunction, but there can be other dysfunctions. Okay, so this leads to proteinuria, and again, when there is less protein, less albumin in the blood, that decreases the oncotic pressure, and when that oncotic pressure is decreased, that leads to increased transfusion of serum from blood vessels to the tissue. Okay, so this leads to edema. Okay, so this edema is not, of course, happening in the kidney, it's happening elsewhere in the body, like in legs or in your hands, because of decreased oncotic pressure, and that oncotic pressure was decreased due to proteinuria. Okay, and then in lungs, of course, there is hypertension, and hypertension leads to left ventricular dysfunction, that would lead to increased hydrostatic pressure in the lung capillaries, and that will increase capillary permeability. So increased hydrostatic pressure is due to vasoconstriction, and increased capillary permeability is due to capillary or endothelial dysfunction. And what will that do? That will lead to increased movement of fluid from these pulmonary capillaries to alveoli. And what would that do? That would cause pulmonary edema and respiratory distress. Okay, and in liver, again, there is vasoconstriction and there is microthrombi obstruction. So when there is endothelial dysfunction, of course, because of the vicious triad, there would be thrombosis. Okay, so because of that thrombosis, again, vasoconstriction and thrombosis will lead to decreased blood flow to these liver cells, and this will cause liver dysfunction, impairment, liver swelling. Okay, and again in CNS, same mechanism everywhere. There is endothelial dysfunction and there is vasoconstriction, and that leads to disruption of blood flow, and that manifests as certain symptoms. So in CNS, that leads to spasm of vessels in CNS, and that causes seizures. So when there are seizures present, so this is important. So in preeclampsia plus seizures, that is eclampsia. Okay, so that's different from preeclampsia. So when there are symptoms of preeclampsia plus on top of that there are seizures, this is termed as eclampsia. And when a person has eclampsia, we give her magnesium sulfate and we deliver the baby. Okay, no matter the gestational age, we just deliver the baby. Okay, so here are the diagnostic criteria. These need to be fulfilled for us to diagnose it as preeclampsia. Okay, so there is hypertension, of course, hypertension plus proteinuria, and proteinuria can be evidenced by any of these. So 24-hour urine collection, it should be equal to or more than 300 milligram per 24 hours, sorry. And urine protein over creatinine ratio should be more than 0.3, or urine dipstick should be 2 plus protein. So this is not very objective. These two are measurable. This is kind of subjective. This is the gold standard 24-hour urine collection. Okay. So this is preeclampsia without severe features, and without severe features and with severe features, and they have a bit different management. So we will talk about that later, but now we are studying the diagnostic criteria. So if there is hypertension plus there is proteinuria, that's without severe features. With severe features, again, we have gestational hypertension plus we have one or more of the following. So if the hypertension is like blood pressure is very high, so it's 160 over 110, then we call it severe features. Or there is thrombocytopenia, or there is renal dysfunction. Also, so how do we know that the kidney is not functioning properly? If the serum creatinine is more than 1.1, or if the serum creatinine level has doubled. So say that a person already had renal dysfunction and her creatinine were 2 mg. So if it moves to 1.1, that doesn't mean that she has renal dysfunction because her creatinine decreased. So we go with this criteria. So it needs to be doubled here. But if it was normal before, then if it moves to 1.1, then we call it renal dysfunction and we'll label it as severe feature. Okay. If there is renal impairment, so if the transaminases AST/ALT, they are more than 2 times the normal upper limit. So if they are in like between 100 and 200, we would term it as preeclampsia with severe features, or there is right upper quadrant pain, or there is epigastric pain, or there is pulmonary edema, or there is new onset hypertension. New onset headache. Okay, so if any of these is present and there is preeclampsia, then we call it preeclampsia with severe features. Okay, so HELP syndrome is kind of a variant of preeclampsia, and it has all of the following. So HELP is kind of it encompasses all the findings. H is for hemolysis, EL is for elevated liver enzymes, and LP is for low platelets. So if all these are 3 present, then we call it HELP syndrome. And again, we deliver the baby. Okay, so in eclampsia we deliver the baby, in HELP syndrome we immediately deliver the baby. Okay, so how do we manage preeclampsia? So if the patient has preeclampsia without severe features, so this table is for without severe features, we of course admit the patient. Okay, because we have to monitor her continuously. So depending upon the blood pressure range, we have a bit difference in the management. So if it's less than 150, so if it's less than 150, we don't give any antihypertensive drugs. If it is between 150 and 160, we give oral labetalol. Again, if it is between more than 160, we also give oral labetalol. That's the first line drugs. We can also give other drugs. Okay, so we have to measure the blood pressure every day at least 4 times. Okay, if it's more than 160, we can measure it more than 4 times, and we don't have to repeat proteinuria. Okay, so proteinuria we need it for diagnosis, but we don't need to monitor it every time. Okay, so once we have established that the person has preeclampsia, we don't need to repeat the quantification of proteinuria, and we have to do certain tests at least twice a day. There are kidney function, electrolytes, CBC, transaminases, bilirubin, because if any of these is deranged, then we label it as preeclampsia with severe features, and then the management is a bit different. So if the person has preeclampsia without severe features, this is the management. We manage her like this till 37 weeks, that's term, and at term we deliver the baby. So that's a planned delivery. We induce the labor and we deliver the baby. So there is no kind of complication of the preeclampsia, because at 37 week the harm of the preeclampsia developing severe features are more than the benefit of keeping the baby, because the baby has already developed enough. So at 37 week, it's very wise to just deliver the baby. Okay, so then we move to preeclampsia with severe features. And what's the management? So first we have to stabilize the patient. Okay, so immediately we start IV antihypertensive. So for pregnancy, there are certain antihypertensives that are recommended. They include labetalol, they include nifedipine, hydralazine. So these are the main ones. So we start any one of these IV, and then we administer magnesium sulfate for seizure prophylaxis. But an important point here is that if the person has myasthenia gravis, then magnesium sulfate here is contraindicated. Okay, so magnesium sulfate is contraindicated. So what do we give a patient with preeclampsia with severe features and she also has myasthenia gravis? We give her valproate. Okay, so valproate in myasthenia gravis. In every other patient, we just give magnesium sulfate. Okay, and then we monitor her blood pressure, her oxygen saturation, her urine output, and we manage any complications. And then we have to see that if she has any indications for immediate delivery. Okay, so we will learn about indications for immediate delivery. Okay, so if she has developed eclampsia, which means there are seizures, there is pulmonary edema, DIC, abruption, or there is severe hypertension that is refractory to antihypertensive. So we have given her IV labetalol, IV nifedipine, IV hydralazine, and blood pressure is still not coming down, then we will deliver the baby immediately. Or there are signs of fetal distress or fetal demise are unlikely to survive. So if the fetus has already passed, or we know that the fetus would pass away, no matter what we do, we just deliver the baby. So these are the these are the indications of immediate delivery. And what does that mean? That immediate delivery, it means that no matter gestational age. Okay, so even if the baby is, the gestational age is 28, we still will deliver the baby if there are severe features, there are indications for immediate delivery, and we don't even wait for giving the baby steroids. Okay, so normally what we do is that if we have to deliver a baby early, we first give the mother IV steroids, and that increases lung maturation, that helps lung maturation, and then we deliver the baby. But if there are immediate delivery indications, we just deliver without even waiting to give steroids. Okay, so now if these immediate delivery indications are absent, okay, so there is no indication for immediate delivery, then how would we manage preeclampsia with severe features? Okay, so we have to remember this is for severe feature preeclampsia. If it was without severe features, we just give antihypertensive, we conservatively manage the patient, we monitor the patient, and we deliver at 37 weeks. Okay, but now if she has preeclampsia with severe features and there is indication for immediate delivery, we just deliver the baby regardless of age. But if there are no indications for immediate delivery, then we see gestational age. So if it's more than 34 or 34 weeks of gestation, we deliver again. Okay, so again, if there is indication for immediate delivery, we deliver no matter the age. If there is no indication but there are severe features, then we see the gestational age. If it is more than 34 weeks, we again deliver the baby. But here there is a difference, we give steroids. Okay, so earlier we were doing is that we didn't even give steroid, we just deliver immediately. But here we have some time, so we first administer steroids, and after steroids we deliver the baby. Okay, that's when the gestational age is more than 34 and there is no indication. Okay, but if the gestational age is between fetal viability and 34 weeks, then we assess the fetal and maternal status. If the patient is unstable, then stabilize and proceed with delivery. Okay, so if she is unstable, then we stabilize her and we deliver, because we know that she will again unstabilize, and that might lead to permanent damage to mother or the baby. So we just deliver even if it's before 34 weeks. But if the patient is stable, we administer steroid for lung maturity, and we consider an expectant management in this patient. So for us to consider expectant management in a patient with preeclampsia, there is like a long list of checklists that we have to go through. So firstly, okay, of course it is in severe features, she should not have any indication for immediate delivery. Then she should be below 34 weeks of gestation. So if it's over 34 weeks, we deliver. If it's below, then we see if she's stable or unstable. If she's unstable, we stabilize and deliver only if she is stable. So below 34 weeks, no immediate delivery indication, and on top of that she is stable, then what we do, we give steroid and we manage her conservatively with strict monitoring of fetus and maternal status, and we do this till 34 weeks, and at 34 weeks we will deliver. So with severe features, we deliver at 34, we try to deliver at 34 in fact. But if there is indication for immediate delivery, we deliver it before. If the patient is unstable, we deliver it before 34. If the patient is stable, no indication, we deliver at 34. But if there are no severe features, we manage the patient conservatively and we deliver at 37 weeks. Okay, so I hope I was able to make myself clear. Thank you.